Hello and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, Healthcare C-Suite, Prepare for PHE End and Regulatory Changes. We're pleased that you've joined us today, and before we begin, I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1.5 CPE credits. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 75 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only one sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and now with that, I would like to turn it over to today's moderator, Stacy Stelzriede, Partner and National Practice Leader of Hospitals and Health Systems here at Moss Adams. Stacy?
Thank you, Amy. It's my pleasure to be moderating today's webcast. Thank you all for joining us. With me today is Mike Newell, who leads our provider reimbursement practice, Karl Rebay, who leads our healthcare strategy and integration practice, Riter, specializing in revenue cycle, and Melaney Scott, who specializes in compliance and internal audit for healthcare organizations. We'll spend the next 90 minutes discussing significant areas impacting healthcare providers as a result of the end of the public health emergency. This will include how the PHE will affect your revenue streams and payer mix, and how to prepare for any unintended consequences. Also, ending of waivers and other implications you should be aware of, and most importantly, some key takeaways really to ensure that your leaders are prepared to address the changes that are coming. Let's move to our first polling question.
All right, Stacy, the first polling question is pulled up to our audience. They are located right on the slides that we're presenting. You're going to click the button next to the answer you choose and hit Submit.
Okay, so at this point in time, what's the estimated impact on your organization's revenue following the end of the PHE? Some of you may are pretty deep into assessing that, and others maybe have some assessment to do on that front, or you may have no idea. While we're waiting for the results of the poll, just also want to make sure everyone's aware, you can answer, put in some questions in the Q&A. We'll do our best to get to those throughout the presentation or at the end. And if we do run out of time, we will follow up with those who submitted questions. All right, so looks like manageable impact in preparing for the changes compared to those of you who are also in the middle of trying to ascertain what the impact is. So we certainly hope that today will help you least get an inventory or better inventory of what's out there and what's coming. So with that, I'll turn it over to Mike to kick us off with our first topic.
Thank you, Stacy.
Actually, I apologize, Mike. Yeah, sorry, I jumped ahead. Yeah. So it's just a little background before I turn it over to Mike to dive in. On the next slide, just really summarizes really how we got here, right? The public health emergency was declared almost 3.5 years ago. That seems like it wasn't that long ago, but we're already 3.5 years in, and that was on January 31st of 2020. And that included legislative, regulatory, and administrative action. The declaration, as you all know, provided providers to maximize the flexibility that you needed to deliver the care, and modified also some payment provisions so that payment could be made under those different scenarios. With the public health emergency scheduled to sunset next week, many provisions will be discontinued. However, there will be some that do remain. So we'll move right into the meat of our presentation here and get into some of those changes that you should have your eye on. Mike, I'll turn it over to you.
All right, Stacy, thank you. So let's kind of we're going to begin with this Medicaid eligibility redetermination period that just got underway. Obviously, there's been a number of changes over the years to Medicaid and Medicaid eligibility, and particularly as it relates to payment streams such as Medicare DISH and claims payments that you would receive. But what you're going to embark on now is a pretty significant change. The Families First Act provided fiscal relief to states during the expected significant economic downturn associated with the pandemic, and to address additional costs associated with the increase in Medicaid enrollment. And as part of that, Congress instituted a continuous coverage provision. So as you know, the typical scenario is there's sort of a constant flow of eligibility determinations that are made throughout the year in Medicaid programs. And over the years, that flow could result in a net growth in the rolls for a state, a net decline, or the number of enrollees remaining flat. But to help preserve coverage throughout the pandemic, the federal government incentivized states to keep enrollees continuously covered until the end of the PHE by implementing an enhanced federal match. So there was an additional 6.2% add-on added to each state's already existing federal match rate. And that ultimately totaled about $40 billion per year across the country. And but in order to receive that additional money, states could not terminate a recipient's coverage unless the enrollee requested termination, or they moved out of state, or they died. And this provision played a critical role in preserving healthcare coverage for the newly qualified that may have qualified because of the significant upheaval, in the employment base and other economic factors, but also maintain coverage for those enrollees that might have lost coverage through the administrative churn process, which is the result of some defect in the annual renewal process. And the legislation that was passed at the first of the year set April 1st, 2003 is the date these determinations would become effective. So in terms of what effect this had on the overall role, and I'm basing this information primarily off a recent Kaiser Family Foundation study, the pre-pandemic baseline, we had enrollment of approximately 88 million people in Medicaid, and over the period of 20 to 22, that number grew by over 25%, or over 22 million people were added to the rolls. Now, it's estimated that 84% of that addition is actually the result of this continuous enrollment provision. So therefore, that kind of churn on and off or off and never back on again because circumstances change did not occur normally as a result of this provision. And then in terms of the money, the study indicated that the estimated cost to the state of covering these additional people was about $47.2 billion from 2020 to 2022. But the additional federal money that was received for the states was over $100 billion. So we've got kind of a double-edged sword going here. One is the states will be losing this additional 6.22% that was covering the additional cost of these enrollees. But because the amount being received in many states was greater than the cost, then that was making a net positive contribution to the state budget shortfall. So both of those things have to be kind of dealt with. And I know, Richard, you're going to talk a little bit more about this when we get to your section, but I didn't know if you had a couple comments in terms of that piece.
Yeah, I think this is a really important point. You know, when this was originally set up, I don't think any of us expected it to result in a windfall for the states. And, you know, we're seeing this being eliminated right now while states are tightening their belts. You know, the Fed keeps increasing interest rates. The states have a lot of other priorities. You know, and we're seeing providers, of course, you know, the past year and a half has just been horrendous losses for a lot of providers. So the risk here is that state funding for Medicaid programs is going to become just another headwind as the health systems try to do their turnaround here.
Thank you, Richard. Now, in terms of the the money part of this unwinding for the states, as I said, the dollars that began to phase out are per the schedule that we've got outlined on the slide. And as we'll discuss in future slides, there is a planned unwinding process that states are supposed to adhere to. Many states could have and actually have begun working on this, if no other reason, in the planning process. But no enrollee should have been removed from Medicaid eligibility rolls before April 1st of 2023. And the redetermination process is scheduled to be completed within 14 months of it beginning. But you can see from this schedule that the additional money steps down to zero between now and the end of this year, and that no longer will be paid to the states. So the so-called pace of this unwinding may vary greatly among states as they wrestle with this idea of the money's going away, and the money was not only covering the cost of the additional people, but it was also contributing positively to the state's budget. But then also marrying that with the fact that they've got the practical reality of how to address this situation, because right now the project is to perform redeterminations for everyone that's on the state rolls right now. So let's talk a little bit more about the actual numbers, and we're going to highlight basically three different studies. And really what this looks like is a little bit unclear. And there were some studies performed on pre-pandemic data sets to kind of see what happened to people when they fell off the rolls. But the first one is the Kaiser Family Foundation, and they've got a wide range here between 5 and 15 million people will come off the rolls. And that's based on two different assumptions, one a 5% decline and one a 13% decline. And really the difference between the two was how they're factoring in the churn and to what extent there will be a churn. So in one scenario, that there's a robust redetermination process and the so-called churn takes place and more people come off the rolls, and another is not as robust and it doesn't affect as many people. I think the Health and Human Service estimate is is what seems to be falling into kind of the sweet spot of a number of different ones. The government estimates about 15 million people will come off the rolls. But importantly, of that 15 million people, it's estimated that 6.8 million would likely still qualify, but could just get washed off the system as a result of a number of things, most of them administrative, such as the high volume of redetermination that the states are going to have to deal with, the length of time that has elapsed since Medicaid agencies last communicated with enrollees. You know, with this continuous enrollment period, this back and forth with people and updating information and staying in contact, you know, that kind of was not in place. Increased a number of homeless people and difficult reaching them. The over-reliance on physical mail, and you'll see that there's some things put in place in terms of what to do with return mail. Concerns that too short of a response time is going to be given for responses due to outreach from the state. And then there's also kind of this administrative issue of numerous redeterminations within the same family that may be on different timelines. So it's kind of like a multiple touch scenario as opposed to a one-time, one-home sort of thing. And then the Medicaid offices are short-staffed. I know that's no surprise. Short staffing is no surprise to people listening today. And then there's many new people in the Medicaid office, number of which have never gone through a process like this. So we've got to deal with all of that. In terms of the Urban Institute, they also estimate about almost 15 million people, but theirs is a gross estimate of 18 million minus a little bit over 3 million children that will move from the Medicaid to the separate CHIP program, which is just a little bit different program. They base their estimates on a tool that they've historically used called the Health Insurance Policy Simulation Model. And it was in their study came out in December of 2022. And they are, in this study, did kind of look at the pre-pandemic period to try to get an assessment of, well, what would this look like in the past when you went through this redetermination process? And based on that study, 65% of people that came off of the Medicaid rolls had some period of uninsurance within the first 12 months after they came off Medicaid. And about 41% of that group re-enrolled in Medicaid within the year. So there's kind of your churn. And these things occur as a result of a number of items, such as short-term changes in income related to the potential enrollee, other circumstances in their life that make them temporary and eligible, and then obviously administrative reasons, which we've talked a little bit about already. And then, as I mentioned, each state is working within an unwinding window. There was a survey conducted by, I think it was Kaiser, to states to get an assessment of what they were thinking here. And most states that responded to the survey indicated that they were going to wait till March or April to even begin this process. And then most planned to take the 12 to 14 months to go through the process and return to normal operations. And the reason for that was to try to not overwhelm their current staff, as well as deal with the issue of hiring new staff, and then also just to help prevent inappropriate termination. So that's a good thing. If they don't rush to this, then maybe that they can mitigate. We can mitigate some of this 6.8 million estimated movement of people that actually do continue to qualify to be on the rolls. So in terms of efforts, most states are adopting a process that's geared towards first targeting the potentially ineligible enrollees early in the process and deal with them, and delay action on the more vulnerable groups so that there could be more of a deliberate effort to address them. And then the states have done this in the past, and there's going to continue to be a high use of this ex parte renewal process. And I'm going to talk about that a little bit more in a minute. But that the use of that will hopefully reduce the administrative burden and minimize disenrollment due to enrollees being unable to complete the process or having meaningful conversations with individual. And then, as I mentioned, there's staffing issues. Of the states that responded to a survey regarding staffing, half the states reported greater than a 10% staff vacancy rate in their states. So some of the measures that they're implementing to mitigate is obviously to authorize overtime. Others is to use the more highly utilized contract workers, and then they're all working on new hires. And under the Families First Act, there are a host of other requirements that states must adhere to in order to continue to qualify for the enhanced match. And those are on these slides. And I'm just going to hit on a few of them. We already talked a little bit about the ex parte renewals, and essentially the instructions from CMS is if the state is able to do so on a reliable information basis, then they can begin the new renewal process without requiring information directly from the individual. And there's a whole host of databases that states could access to try to pursue this. And for those that they can't get underway utilizing some ex parte means, then CMS is directing the states to provide a renewal form that's basically as short as possible and only includes solicitation of the information that's absolutely necessary in determining eligibility. And so, for instance, avoiding trying to accumulate a lot of other information that maybe the state already has, and just a repeat basis. Also to provide reasonable timeframes, give people adequate time, recognize, there's some difficulty in reaching this population, and time is needed to do it. And then to evaluate the responses and cover all bases in determining Medicaid eligibility. Most states have a whole host of programs that individuals can potentially qualify, and then provide adequate advance notice and fair hearing rights prior to a determination to remove someone from the rolls. And also in terms of reliable source information, CMS has also indicated that the state can rely on information directly received from the beneficiary if it's in response to a specific outreach campaign. So if the state's working with some community partners, even hospitals, that help with this outreach program, and the response comes directly from the individual, the state could consider that reliable information on which to act on. And attempts to reach people should be recent. So states can't rely on some information they had 3 years ago and make an outreach based on that and then determine that they can't find people. And then I think a big item here is to utilize more than one modality, recognizing that obviously many of these are not available to everyone, but to utilize the mail, telephone, email, text, and online portals. And again, I think this dovetails in not only with what the state is going to do and what outreach partners might be working on, but I think there's a role here for hospitals. And I know this kind of, Richard, this may tee up something you're going to talk about in a minute as well, but I think you might have a comment here.
Yeah, thanks, Mike. And yeah, I completely agree. I think, what's interesting here is that CMS is being really prescriptive in some of these areas, but they're leaving a lot of room for states to build their own processes as well. And so, in addition to, I think everything, Mike, you mentioned, one of the other things I would suggest is that providers really pay attention to the details of their state's approach. And in the case of, multi-state systems, what I think we're going to see is each state is going to have to be kind of followed separately because they're each going to have their own approach, and so that's going to make it even more complicated. And yeah, absolutely, to the extent that health systems can be part of the solution up front, I think that'll make it all more seamless as well. So definitely suggest that.
Perfect, thank you. Also, as part of as part of this is transparency and recognizing that there there likely will be delays, but there was a new section added to the Social Security Act calling for the requirement for states to submit monthly reports during the period April 1st, 2023 through June 30th, 2024 about their activities related to this eligibility redetermination process. Some instructions were issued back in January of this year that I'm sure continue to be tweaked, and this information is supposed to be reported and available online, but it's going to include data on the number of renewals that were initiated, the actual number of renewals that were granted, and of the number of renewals that were granted, how many of those were granted on an ex parte basis, so we can get a sense of how that program is working. Obviously, the number of terminations, and of those determinations, how many were terminated for procedural reasons. So procedure versus just no longer meeting the eligibility criteria to be on Medicaid, and other things like how many people migrated to a separate CHIP program, some statistics regarding effort conducted by state call centers, call center volume, wait times, abandonment rates, things like that. And then there's a federal marketplace and the state marketplace where states are also supposed to be helping to facilitate the review of other options for people. So there's data that's going to be reported on that as well. So with that, let's talk a little bit about kind of the implications, and we're not going to cover all of them, but some of the bigger ones. So clearly, this sets up for a shift in payer mix from Medicaid to uninsured, or to the exchange, or even to other places. Based on the Urban Institute's data of 15 million people coming off the Medicaid rolls, and utilizing a prior study, they're estimating right now that maybe 9.5 of that group will qualify for employer health insurance, and will just shift to that. I think that's, as you know, is a moving target as we continue to wrestle with what's happening with inflation and where we are in terms of a recession, or are we in a recession? Are we going to have a recession? How deep is that? How is that really affecting the employment base? About 1 million maybe will move into the exchange. Almost 4 million are estimated, based on this study, to remain uninsured. So that has its own new host of issues. And so in terms of, services and claims payments, maybe the migration of 9.5 million people from Medicaid to employer health insurance on a claim-by-claim basis, maybe that's a good thing. Maybe that's not a good thing. It's a good thing if the insurance is paying and those rates are higher than Medicaid. It's maybe not such a good thing if the plan that they're eligible for from an employer standpoint are high deductible, high co-insurance, and high copay plans, such that when they do receive services from the healthcare system, they're really considered self-pay because they haven't, met their high deductible in order to tap into their benefits. So that's going to be something that you're going to have to work through that plays out. But moving people, regardless of where they go, moving people away from Medicaid has pretty significant federal and state payment implications. On the state standpoint, most state Medicaid DISH plans and even uncompensated care plans utilize Medicaid adjudicated claims in addition to uncompensated care costs to determine, in some cases, qualification and in payments. So obviously moving off the rolls will affect that. From a federal standpoint, there's a few touch points here. One is obviously Medicaid days factor into the Medicare DISH payment calculation, and that will potentially hit hospitals in two ways. One is the reduction in the Medicaid days will potentially impact the so-called empirically justified component, which is a $3 billion component that hospitals share in today. And that is everything from reducing a hospital's share of empirically justified DISH to actually even resulting in them not qualifying for DISH at all. And if that occurs, then you not only lose your piece of the $3 billion, then a hospital is no longer eligible to receive a distribution from the uncompensated care pool. And that pool for 2024 is estimated to be $6.7 billion to be split among 2,400 hospitals. So if you lose qualification, there's a lot on the table. And even if you retain DISH qualification, then you've got some additional things to worry about for community hospitals and rural referral hospitals, and that's meeting the 8% threshold to qualify for 340B eligibility, or to exceed the 11.75% payment add-on threshold to qualify as a DISH hospital, which obviously has big implications on whether or not the hospital will receive the benefits associated with 340B qualification and orphan drugs. And before we leave this point, I wanted to invite Karl into the conversation, because obviously we've been talking a lot about what goes in the numerator, and that's of the Medicare DISH calculation, and that's Medicaid days. But let's talk a little bit about the denominator and service line optimization and some other metrics. Karl, would you comment on that, please?
Yeah, happy to. Thanks, Mike. Part of what I'll be talking about a little bit later involves some sort of mitigation strategies, if you will, related to dealing with the impacts of the end of the PHE as they're being described here. And, some of those strategies are about driving more refined volumes or access programs that define as, within service lines, doing strategic moves that will maybe change the patient mix and payer mix and whatnot. And a lot of the work that's being done is to address capacity problems that are occurring in health systems. And, the ultimate goal there is to, really do things like reduce average length of stay, things that will sort of save on cost, enhance quality for patients, and get folks through a care episode in a more efficient manner. And also, contemplating moving things into the outpatient setting. I mean, we've got a lot of that going on in the industry right now, more so of a push than before, I think. And so what you have to do when you're contemplating those strategies is make sure that you're paying attention to exactly what you've been describing here, Mike. Because anytime you're doing something that's going to reduce the number of days one way or the other, especially if you're related to 340B, if you're kind of close to that threshold, you've got to really pay attention to what's going on. We're recently working with another client, or with a client that was looking at moving a segment from, into an outpatient setting, into a different setting. And it was not an immaterial, sort of volume. And that they had to very closely look at the ratios to make sure that they understood the impact of 340B. And a lot of organizations will especially as, the broader implications of the end of the PHE are impacting these numbers, the number of qualified beneficiaries and whatnot. It becomes ever more important to make sure that you really understand what it is you're doing and all the potential implications.
Thank you, Karl.
You bet.
And so now let's pivot to a couple of other quick items, and then we're going to move on to talking more robustly about some of the things that hospitals can do. Recently, CMS changed the reporting requirements associated with Medicaid eligible days for the DISH calculation, and charity care and non-Medicare bad debts for the uncompensated care calculation, and the claiming of Medicare bad debts, which for most of you, is a significant payment stream for unpaid deductibles and co-insurance from Medicare patients. This is creating a significant reporting burden on hospitals that was not in place prior to this change, commonly referred to in the industry as Transmittal 18. And we've been having a lot of conversations with, and I'm going to invite Melaney here, with Melaney and her group, and clients and compliance officers and internal audit professionals on how to get their arms around these additional upfront reporting items and what layer of burden and compliance are associated with this. So Melaney, could you speak to that quickly?
Absolutely. Thank you, Mike. So as he mentioned, and I think it goes without saying that we all want our reports to be accurate, and especially those going to government agencies. And really with this, we do have that risk of underlying data being incomplete or inaccurate, especially because some of those brand new data elements, in addition to perhaps being a challenge to quantify to report, also making sure they're pulling from the right places. And during those discussions that we've been having with internal audit and compliance folks, asking, what work they might be prepping to do around this. In a lot of cases, this was new information for them. And so it's just a really good opportunity to maybe dig into this Transmittal 18, what is required of it, and see how your compliance and or internal audit departments can help leverage to really get it set up on the front end to ensure that there is the accurate and complete data being captured. Thanks, Mike.
Oh, thank you. I appreciate it. And then the last thing, some recent information continues to unfold with this, but I want to finish with just a quick note about sort of this looming large item related to the solvency of the health insurance trust fund that we all read about, depending on the source, and including even the government. Right now it's expected that the trust fund will be depleted somewhere between 2028 and 2030, with 29 being the year that the fund balance itself reaches zero. And that means from that point on, and based on current data and expectations, the amount of benefits paid out will exceed the amount of revenue paid in from payroll taxes. And so I say that because on top of all these other changes, we sort of have this looming budget problem out there that at some point is going to have to be addressed. And there's multiple things that can be done in isolation, or those things can be done in cooperation with each other. But in likelihood, there's going to be some impact to payments on hospitals in the future to try to help shore up the trust fund or a change in payroll taxes. So on top of all this other stuff, I think it's important to keep tabs on sort of what's happening on a federal level in terms of the fund and what kind of things are being done to extend that solvency period. So with that, I think I'll now just officially turn it over to Richard, and let's start talking more about things that we can do that we control within the hospital. So Richard, with that, I'll turn it over to you.
Yeah, thanks, Mike. Thanks for turning it over on such a happy note. That doesn't seem like too far away, does it? So talking about some things.
Richard, I think we lost your audio.
Let me try again. Now? All right,
yes.
There we go. I don't know what happened. Thank you. All right, so so start over here. So I think there is a lot that providers can do to make the redetermination process smoother for both patients and for the internal teams. It's going to put a lot of demands on patient access staff, particularly financial counseling. We'll have patients who have not have recently lost coverage. They're coming in for service. And it's been, over 3 years since these continuous enrollment requirements were put in place. With staff turnover, a lot of the patient access staff who are in place today may not have even been in their roles before these pandemic changes happened. So training will just be absolutely essential as a starting point. Moving on from the training piece of it for patient access, I do think that getting some procedures in place to proactively analyze the internal data to identify patients whose Medicaid coverage has lapsed will be really valuable as well. And like Mike mentioned, we expect that many of the people who lose coverage through this process are actually still going to be eligible, but they may just be slipping through the cracks here in the state process. So that's going to be really important. And then, one of the great resources here that I would encourage all the providers to work with is your Medicaid eligibility vendor. Many of these vendors have been preparing for this transition for a long time. And so I would recommend connecting with them to make sure you're taking advantage of everything they have to offer. And then lastly, from kind of an operational perspective, I would suggest, again, looking at the state-specific unwinding plan, and to the extent that you can work with, like say, a hospital association or other professional association to help keep track of that, I think that'll be a really valuable group to work with and to stay apprised of the developments there. Another area that I would suggest is policy and procedure review. So, I think it's pretty obvious, something like your financial assistance policy would need to be reassessed here. If you do have separate policies that impact bad debt and collections or patient intake, I would suggest you take a look at those as well as part of this process. And with that, I will transition here to the next polling question.
All right, thanks, Richard. So next question, and if you're concerned that you've missed a polling question, this is just our second one. So if you answered the first one, you're caught up. The results of the Medicaid redetermination process will impact most hospitals, some more severely. Based on your analysis, are your action efforts commensurate with expected impact? And Mike, while we're waiting for that answer, I thought I'd throw out there just real quick, there was a question that came in. Is the $15 million decrease that you mentioned in Medicaid enrollment, is that a cliff ending or gradual throughout the next 12 months?
If the survey respondents indicated that they were going to take the entire 12 months. But I don't know that necessarily means it's going to just be a linear decline. I don't think it's going to be a cliff either. I think there may be a cliff at the beginning and then a decline from there. But it is a big effort for the states to undertake. And if they could undertake it in a very quick fashion, I think you would see a cliff. But because they can't, I think it will be a decline. I don't know if steady. I don't know if I'll go that far.
Okay. Thank you. Great. So here's the results of the question. So about 33% fully engaged and actively working, and 40% in that assessment phase. All right. I'll turn it back over to Richard.
All right. Thank you. So next up, I want to move on to from discussion of the Medicaid redeterminations and spend some time on some of the other impacts related to the end of the PHE. And just for fun, a couple weeks ago, I asked one of these AI chatbot tools what the impact of the PHE ending would be for healthcare providers. And the good news is that we still all are going to have jobs here for a little while at least, because it couldn't really figure it out. It actually did a little bit better than I thought it might, but it included some extraneous information about people starting to travel more and things. But the biggest area that it couldn't really figure out was which impacts would supersede the others. And I started thinking about that, and think about all the changes that were made early in the pandemic. Some of those have expired. Some will be expiring soon at the end of the pandemic here next week. Others were extended through the Consolidated Appropriations Act or something else. And the AI tool just couldn't, it had no idea really how these all should be woven together to put a story together. And I realized that's what's driving a lot of the challenge that we're all facing as we're trying to figure this out here too. And it's, it's a little bit like if you go to the fair and you see those like funhouse mirrors where you can't figure out kind of what reality actually is, because there have been so many different iterations of this over the last couple of years. And the first change has already really happened, which is initially we were all looking to the federal government primarily for grant funding, and that grant funding is really all dried up. I remember when the CARES Act was originally passed in 2020, working with the team I was part of at a health system where we were trying to figure out how it was all going to work and what the reporting requirements were going to be. And most importantly at the time, really, we were facing a cash flow crunch. Every provider was, and so it was really kind of when's the cash going to start flowing. And at this point, I think it's safe to say that that cash has flowed. There is really no more cash to be seen, with the possible exception of something for FEMA. We all have some great single audit experience. Maybe we think that's great, maybe not, but we all have that experience. I think there's a debt limit bill that's currently in Congress, and at least in its current form, it would rescind the unspent pandemic funds. So to the extent that passes, it really would kind of officially wipe away any other funds that might be out there. But I think, regardless, there really isn't anything additional that's going to be coming through to providers. So on top of that, then, on top of kind of all the money being spent, we are starting to see some audit activity. I know, Melaney, you've been doing some work with providers on some of these audits. What have you been seeing?
Yeah, thanks, Richard. So specifically around most of the centers on the provider relief funds, and among many other things. But when we think about those, so if an entity, one of your providers did receive enough provider relief funds to become subject to the single audit, and you've got through that, you may have some other ones coming up depending on the timing of when you receive some of those disbursements. But as we know, HRSA and the Office of Inspector General, the OIG, are also conducting audits. And so we're watching how this is playing out. So some of the ways we're seeing this is with the OIG, they had a work plan item back from 2022 that came on. And it was around, the way that was framed was around the provider relief fund balanced billing prohibition component in those terms and conditions documents. And so OIG is still actively working on this audit, and we're kind of waiting to see what that report looks like. But historically, that report is given to the agency with responsibility over that particular grant or program. So in this case, it's expected that it's going to go to HRSA. And that could also trigger some additional audits of entities. With this OIG work plan item, there were 30 healthcare entities that were selected to be part of the sample for this audit. And so if you weren't one of those lucky ones that are participating in this OIG audit, very well HRSA could come back depending on the results of this and expand, or definitely potentially follow up with one of the entities. And thinking again around this and that balanced billing prohibition that's in the terms and conditions documents, having discussions with organizations, because many organizations also participated in the uninsured and the underinsured reimbursement program, which we know that program ended back in 2022. And that program had its own set of balanced billing prohibition. And during discussions, there was clearly great focus on ensuring that the terms and conditions were met for the uninsured, underinsured program. What wasn't always as clear is how an organization was implementing and had processes around the provider relief fund balanced billing, which was completely different terminology. It would have been different tracking. It would have been different processes. And so I think this is an area really to make sure is solid in your organization, because the way that the PRF balanced billing prohibition is framed in the terms and conditions, it has a much longer extended compliance requirement around that. So just something to think about. And there was lots, each distribution of PRF had its own terms and conditions document as well. So really important to make sure that your organization is keeping that top of mind, is revisiting policies and procedures and processes to ensure ongoing compliance around PRF. Thank you, Richard.
Yeah, thanks, Melaney. This is such a difficult topic. It's something I've been kind of thinking about and struggling with for the past 3 years. And when we all first saw the language, the question was, how on earth are we going to, comply with this? And, what does this even mean? And so, we're still dealing with that 3 years later. And I see a question in the chat around if it's tied to the end of the PHE. And we might have to get back to you on that exact question. It's related. I can't remember what the timeline is in the terms and conditions. I don't believe it's related to the PHE specifically.
Yeah, I would agree with that, Richard, just really quickly, because the way that the is framed within the terms and conditions document is really surrounding patients who have a COVID diagnosis. And so it's not real definitive when that would actually end. And I've been having conversations with attorneys as well, just to kind of get their take on it. But definitely happy to follow up with folks as well who are posing that question as we're getting additional information.
All right. Thanks, Melaney. So we're going to drill down on a couple of topics around how the PHE ending will impact rev cycle processes in particular, and some of the new risks that are being introduced. There have been a lot of changes related to virtual care along with telehealth. Also want to touch on some requirements for medical record completion that could impact staffing. And looking at patient impacts, there are a lot of changes that were put in place early in the pandemic to make sure that patient liabilities weren't going to be an issue, a barrier for patients to receive care, and those are now unwinding. And so, anytime we have something that impacts patients directly, we want to be super careful with that, of course. And finally, there are some, really important changes in the area of physician supervision that I want to talk about as well. All right. First, we'll talk about the flexibility around supervision. And what we're talking about here, when we talk about supervision, it's for certain Part B services, things like diagnostic testing and Incident 2 services that need to be provided under direct supervision of a physician or another practitioner. And prior to the PHE, direct supervision always meant that the supervising professional was physically present in the office suite somewhere, and they were, immediately available to furnish assistance and direction as needed. And, in other words, they didn't need to be physically in the room, but they had to be, there physically in person. The PHE waiver allowed for the supervising professional to be available virtually. And, there was a push to make this virtual supervision permanently, to make that, permanently in place. But so far, CMS has rejected that. And, not to go too far down the Incident 2 billing rabbit hole, it's a whole topic on its own that we're not going to get into in depth here on this call. But I do want to note that for 2023, there is a separate general supervision standard for some behavioral healthcare services that's separate and not impacted by what we're talking about here. So I just didn't want to get those mixed up with this change. And moving on to the next one, as far as payment goes, providers have been allowed to get reimbursed at non-facility rates, which creates payment parity between telehealth and in-person. That provision will expire at the end of the year as well. So that's a 12/31 change. And then next up is some changes around remote patient monitoring, which is a pretty new treatment category just in general. And with remote patient monitoring, what we're doing is we're collecting data that we can use to develop or manage a patient's treatment plan. And it was initially targeted to patients with chronic conditions, but it's now allowed for patients with acute conditions as well. And as of 12/31, CMS is going to revert on this one back to, again, that established patient requirement that they've had in the past for this service.
Richard, one question that just came in on that is, what is the rationale for CMS only allowing remote patient monitoring for established patients?
Yeah, thanks for the question. Yeah, so that's a good one. So remote patient monitoring was originally designed to be only for established patients. And the idea was that a physician would collect medical history, do a physical as part of an E&M service before the remote patient monitoring started. And then during the PHE, as part of the push to allow as much care as possible to get done without that physical interaction, CMS allowed for reimbursement of services to new patients also. So that's sort of how we got here. Melaney, do you want to talk about some of the OIG impacts and what they're looking at on this issue?
Absolutely. Thanks, Richard. So when we think about remote patient monitoring, just last month, so in April of this year, the OIG added a work plan item surrounding looking at remote patient monitoring. And there's information they're looking at is kind of around the services, and as they're changing, what is the nature of the remote monitoring services that are being used? And really, again, because there is risk there. Anytime you have something when it's being done remotely, that things may not, how it's documented in the medical record, how we can establish that what is occurring in those pieces. And I think that also plays into having that established patient relationship as well as a foundation before doing remote patient monitoring. So just as a heads up, this is something the OIG is looking at. And we generally like to recommend that when the OIG is having an interest in a particular topic, that probably would be a good area to also take an interest in for your organization and proactively take a look at those areas and make sure that we're meeting all the requirements. Thanks, Richard.
Yeah, thanks, Melaney. And last up here is medical records. So HIM is often a challenging area to staff, and I think a lot of hospitals were relieved when the guidance came out allowing for some extra time to complete medical records. Now that we're going back to the 30-day rule, my concern is that some HIM shops might not be staffed to consistently meet this. This is a condition of participation in the Medicare program, so it could expose some staffing challenges. All right, and while we're talking about telehealth, I want to touch on some things that are not changing in the next 12 months. The Consolidated Appropriations Act included an extension of some really significant flexibilities through 2024. And we're not going to go through all these in detail, but I did want to touch on them just in the interest of helping us keep this all straight as we, use that funhouse mirrors kind of analogy as we try to keep this all straight as we navigate through that. So first of all, Medicare is allowing beneficiaries in all geographies to access telehealth instead of just those who live in rural areas. There are some state laws and some licensing issues that make this a little bit of kind of a patchwork quilt. So when we start looking at payers beyond Medicare, it gets complicated as well. The next flexibility relates to patients receiving telehealth care at home as opposed to having to travel to a clinic or a hospital or some other facility. Melaney, do you want to touch on some of the compliance considerations when we're looking at a patient's home being their place of service for telehealth?
Absolutely. So as we know now, that is something that was allowed under the PHE, and it's really something to watch as absent additional legislative action after December 31st of 24, which I know is a long way out. Those Medicare covered telehealth services wouldn't be able to be provided in a patient's home or other non-traditional setting. With some limitations around substance abuse and mental health, and ESRD, and some other very specific elements. But really, as we know, this has a lot of organizations we've talked to, providing care in the home has been a wonderful means to, number one, for the patient, and also to help get very, very less acute folks out of the clinical setting to really focus on dealing with everything through the, what we were dealing with the pandemic. So really something to watch. As we note here on the slide, that this currently will go through the end of 2024, but really could have an effect on care delivery and really just patient care from that perspective. And we'll get to it, but thanks, Richard.
Yep. Yeah, thanks, Melaney. So moving on to audio-only telehealth. So the audio-only telehealth has been a little bit controversial. There's a statute in place that requires telehealth visits to be analogous to in-person care, and audio-only telehealth was scheduled to sunset under the CAA, the Consolidated Appropriations Act. It is still allowed for some mental and behavioral services through 2024. So we still have that flexibility here for a little bit longer. And then the last one on this slide that we'll talk about is just for FQHCs and RHCs. They do still have the ability to provide telehealth service, and in kind of the terminology of telehealth, they're allowed to be the distance site provider. All right. Next, I want to talk about some changes that will have financial implications for providers, but I think also some really important operational changes and introducing some new risks. And this is really directly related to Medicare and Medicare Advantage, but a lot of these risks and these issues are going to apply to commercial and Medicaid payers also. We just didn't have the ability to cover all that on this call. This really is going to be pretty generally applicable. So First is telehealth and remote patient monitoring. Of course, we've been talking about those. Those saw a huge increase in volume during the pandemic. And one of the things that HHS did to encourage adoption of these services was to allow providers to waive cost sharing. And starting here at the end of the pandemic, providers will be, again, required to collect patient liabilities for these services. That's a big change. The next area to touch on is for COVID testing and vaccines. And no cost share was actually even allowed during the pandemic for these services, regardless of network status. And this one is potentially even more tricky because not only do we need to make sure our internal teams are aware of this change and we have the systems in place and things, but we also have a patient population and just public at large that's been sort of trained to see these things as free for the last 3 years. So there is like a patient and public re-education component to this one as well. Another change, this one is actually specific to Medicare Advantage, and it relates to out-of-network services for Medicare Advantage plans. If you think back to the early days of the pandemic, hospitals were getting flooded, and everybody was concerned about capacity, right? So there was a limitation that was put on for cost share to allow patients to find a provider with capacity. And as this requirement goes away, it's going to be really important to make sure that we've got the right payers we're contracting with. We might have a change in payer mix with Medicare Advantage payers as this change happens. We want to make sure we're contracted with the ones that make sense for us. Melaney, anything you're working with on these issues, any other risk areas you're concerned about?
Yeah, thanks, Richard. So I think the one thing here is just to make note that there is legislation in process around testing possibly being covered for uninsured folks. And so again, we're kind of watching and tracking all of the legislation out there and getting information out as it's becoming available to us. But just wanted to put that out there that it's kind of one of those pieces that there could be some information coming out that would help in those areas around uninsured folks.
Thanks, Melaney. And the last thing here on this slide to talk about is some of the Medicare COVID add-on patients going away. There was a 20% add-on that was put in place early in the pandemic. That ended up actually being pretty significant for providers. Some commercial payers had similar add-ons, and Medicaid plans did as well. That's going away at the end of the pandemic here on the 11th. There is also so this is actually part of IPPS. There's a new COVID treatment add-on payment. And because that's part of IPPS, it's going to go away on September 30th. It's part of that schedule. So in both of these cases, there's the financial impact, but then there's also making sure that reserve models and rev cycle processes and things get updated as well. And with that, Melaney, I will hand it over to you to talk about some of the other compliance issues that providers should be keeping an eye on as all these PHE changes are happening.
Wonderful. Thank you, Richard. There we go. So what we've got here is, and while many of these we look at are not necessarily specific to the PHE ending, but they are very relevant and things that many organizations are dealing with, as if just the unwinding of the PHE wasn't enough. And one of those is the No Surprises Act. And we've been starting to do and assist folks with internal audits around this, and wanted to share some of the things that we were seeing with this in the case, and maybe to spur some conversations around your organization. In instances where there might have been some work queues that were created to help monitor and ensure compliance around some of the, say, the good faith estimate component, we were finding that the work queues were not necessarily properly populating all the items that were expected. So there were instances where it was falling through the cracks, and the GFE may not have been prepared when it should have been. We were also observing that the process was rolled out across different departments at different times. And as we recall, this required that the No Surprises Act went into effect in January of 2022. And so sometimes we're finding it's not clearly documented which departments when, and when maybe it was moved to more central processes as well. So that really would be a good idea to have that documented, as really technically the requirements started on January in 2022. So if it came across your organization at different times to the year, would really be good to have that clearly documented. Also, what we're seeing just by natural part of the No Surprises Act is there's going to be some increased write-offs. Or some of the organizations aren't yet monitoring what that level of write-offs is looking like to understand what the impact might be to the bottom line. Some just have a manner by process that even if there could be appeal possibility, they're just writing it off. And obviously there's a cost-benefit ratio to that, but some monitoring activities could surely help your organization see how that's looking, and know what to maybe anticipate, and if at some point there are different processes that might want to be put into place. Another element, not specifically on here, is thinking about HIPAA. We've got a really big focus on the 1135 waivers and some of the other pieces on the clinical side, but HIPAA did have, during the PHE, there was enforcement discretion, and that is going to be ending on May 11th as well. And there was really 4 key areas that this discretion was surrounded. One of those was the community-based testing sites for COVID-19, community-based testing sites. Another was the telehealth remote communications, as well as the allowance of uses and disclosures of PHI by business associates. And then online or web-based scheduling applications, and it was around individual appointments for COVID-19 vaccinations. So this would be another area. Again, a lot of the focus is on the kind of waivers that are ending that could definitely affect revenue. Really might be good to make sure, when I think about this, I think about also your telehealth applications and software. You will want to make sure that those are fully HIPAA compliant. There is a 90-day transition period, so it's not like a hard and fast May 11, but 90 days we know goes all too fast. When we're thinking about the audit findings, one of the things that comes to my mind is with single audits, and sometimes there's findings with those, and of course that gets just uploaded, and we are finding that HRSA has been very prompt to respond to providers who may have had a finding and wanting to know what their corrective actions are. And so just be on the lookout for that. You might be experiencing that as well. The Treasury risk management, we just heard earlier in this week of another bank that was having some troubles. And really, a lot of folks are starting to, it might be a good time to really relook at your risk strategy and approach for kind of your Treasury process. And thinking about the ability to pivot quickly, there's a couple of things that come to mind with this. And as we've talked through, there's many components of elements that are ending with the PHE at some point in time, either on May 11th or sometime this year or in 2024. And there's a lot of potential legislation in play. And so really monitoring that, because as we know, we need to have a process in place to, I'm going to say, unwind or undo some of those waivers. But if legislation comes about that could allow some of those things to continue on, either in different ways or in the same manner, how quickly can we not push that button? And because that definitely could affect revenue in a positive way if we can pivot quickly in some manners. And then also I'm thinking about with your internal audit and or compliance department and continuously monitoring the landscape and updating work plans as might be necessary. Oftentimes we have our really big risk assessments in the organization, but really want to make sure we're having a assessment of the landscape and communicating to governance of shifting things that might want to pivot either the work plan or add in or get some external assistance to really make sure that you're in compliance with kind of all of these pieces. And I would say with that, and we could talk on and on and on and on around this, but just some food for thought. Oh, and I was going to say before we get to the polling question real quick, there was a question that came around the comment of a kind of extended period for compliance. And what that's really related to is when we think about provider relief funds, there, and compared to the uninsured, underinsured program is provider relief funds. Number one, you're going to be, an organization is subject to audit at any point in time, as well as with the uninsured. But because we had such a longer time period of organizations receiving provider relief fund distributions, some organizations can have reporting requirements, well into 2024. And so that really wants to continuously be on our radar as far as some of those pieces, because it doesn't have as definitive of a date as, say, the uninsured, underinsured program ending did. All right.
Stacy? All right. Thanks, Melaney. So the third question here is launched. If you could respond, in which revenue cycle area do you have the biggest risk? And again, as I said earlier in the webcast, if we don't get to your question during the live session here, we will certainly respond separately after. All right, pretty spread out. So every organization is certainly different, and the risks that you have certainly unique. So we will move on from here. So narrowing down a little bit more, what area is most top of mind for you? So if you stepped away from your computer after question 3, come back. There's another one, another polling question. So take a minute and identify here which one is most top of mind for you. And it may be all of the above. Wouldn't be surprising. All right. Hopefully everybody's had a chance to respond. All of the above is the winner. So again, not too surprising. Certainly a lot to get your arms around and a lot of changes. Okay, so let's move on from here and turn it over to Karl to talk about some strategy and solutions. Karl?
Great, thanks. Yeah, so I was asked so if you could maybe move your mindset a little to the sort of the strategy side. What I'm going to be covering are some things that organizations are doing to really kind of deal with all of this. Part of it is how are we doing things differently or thinking about things differently coming out of the pandemic, and what are we really, what are the things that we can do to, again, mitigate some of the impacts of the sort of the fiscal issues and enhanced compliance challenges. And, it's safe to say that, there are many complicated implications in all of this. And, the span of operations and, and compliance recreate some financial issues that leaders have been trying to solve before the pandemic. The notion of profitability and things like that. So we had these problems going in. There were funding and other mechanisms that allowed for some flexibility, and now we're kind of going back to trying to solve these problems that we had before. And one could argue that maybe this is a little more short-sightedness and unintended consequence coming out of our friends in DC. But either way, we have to deal with it, right? So, some of the things I want to talk about, some of the things that the more proactive organizations are doing. Things that we see happening out there. And, these organizations are embarking on a more disciplined efficiency strategies, revenue maximization efforts, and transformative missions that, are really looking to solve the problems solve these problems in a very sustainable way. And I mean, when I say revenue maximization, I mean, of course, in the world of appropriate, in the realm of appropriate revenue, but looking to do things that are really sort of squeezing the orange, if you will, and getting as much juice out of it as possible. leaders are really seeking transformation. It's a buzzword that's probably used too often, but this is kind of a different paradigm that we're in. They're looking for fundamental change in the way they do things at hospitals and health systems, in particular, with survival and sustainability, being the true mission. So 2023 things are kind of coming around a little bit, certainly with organizational investment returns and things like that. So not quite as bad as 22, but just because there's a little relief now doesn't mean that, organizations are going to be able to survive this the next time it happens. So, or let alone be able to invest in infrastructure, right? Have the margins that you need to replace equipment, pay physicians and, recruit physicians and pay staff. So this is really, these are some bolder moves to really change the way organizations are doing business. And the way you start is by doing a detailed analysis of sort of where you are. What are all the opportunities? And, what are those potential opportunities? And we'll talk through some examples. Also want to develop some short-term solutions that begin to drive change and perhaps identify short-term dollars to shore up cash flow. This is stopping waste once and for all that maybe or suspect is there, but has historically either, kind of been okay or otherwise ignored. Some areas more challenging than others, but you kind of want to identify near-term and longer-term stuff. Again, we'll go through this in a little more detail, but the analysis we're talking of isn't just, it's not just benchmarking. It's looking at, frankly, data that's out there right now that a lot of organizations don't really tap into. It can inform on broader issues, like reasons for poor length of stay performance. That's a big ticket item that requires a lot of work and a lot of energy to change. Patient throughput issues and care variation. These are all big ticket items that are worth millions in any hospital and tens and tens of millions in other systems, and of course much more than the larger regional and national systems. But the path to managing and sustaining the change lies in part in organization-wide efforts, but also in getting the experts and specialists involved in service line strategy that Mike brought up earlier in our presentation. And I'm going to talk a little bit about it. That's the transformative stuff. So in looking at some of the, sorry about that, here we go. Looking at some of those nearer term and longer term focus items, we try to categorize things in near and longer term focus, but you can quickly see, or you should note, that both of these columns, if you will, really kind of sort of bleed over. They have, some of the nearer term items are going to take a longer time to implement full change and vice versa. Take labor and productivity as an example. First thing is that no one outside of maybe some extreme circumstances is going to advocate cutting clinical staff these days. That's not what we're talking about. But what we do talk about, and you heard it earlier in our presentation, is perhaps, it was really focusing on the temporary agency labor and repurposing staff, perhaps. Driving overall efficiency in the productivity world to minimize agency labor is absolutely critical at this time. And everything you read with hospital performance and health system performance is hyper-focused on this. And the operational solutions on the right, the more operational solutions on the right, that they should all have a profound impact on labor. When you think about these items here, maybe without, even system integration, actually, I was going to say maybe without the technology one, but actually you can argue that's part of it. If you take this notion of reducing average length of stay, and a big focus area right now, unwarranted admissions, as well as standardizing things like discharge protocols, those all impact the heads and beds, and therefore can play a role in efficiency and staffing needs of your organization. So just some things to keep in mind. Another example in the supply chain, involves some of the more basic stuff like standardizing purchasing strategies, renegotiating with vendors and things, but it also, as you think of that notion of care variation and focus on the service specific standardization, like order sets, clinical care pathways, you also have to involve the specialists in decisions around supplies. And it usually, you can encounter some pretty strong resistance, as anybody who's kind of dealt with this topic before would tell you, in terms of driving solutions in those areas. But it's important in terms of eliminating waste and improving quality, to be quite honest. So, the idea is to go through your organization and figure out what are those areas where we really need to focus and spend the right amount of time assessing and determining what the opportunity is, and then creating some concrete plans. So I think we're going to jump into a couple of polling questions here. So the question we have, oh, sorry, go ahead, Stacy. That's right, you're taking this.
That's all right. So question 5 here, organizations are rethinking strategies and looking for ways to do things differently post-pandemic, many calling it transformation. How would you characterize your organization's efforts? Has it already occurred? It's underway? It's in your plan? No current plans or not applicable? And again, if you stepped away from your computer, run back. All right, great. A lot of efforts underway, Karl.
Yeah, right. Glad to see that.
So if you are undertaking transformation, so for those of you that responded, you're underway, which area of focus is your highest priority? And if it's not on the list, I was going to say, if it's not on the list, you can certainly throw it in the chat as well.
Yeah, I was just going to say also, Stacy, that I think we're going to include in our survey, which we would very much appreciate everybody participating in after this, that another opportunity to weigh in on a little more detail as well. And again, we can certainly, reply back with if anybody's got questions after the rest of the webcast.
All right. One or more. So we'll look for more in the post webinar survey on what those are. Karl, back to you.
Yeah, thanks, Stacy. Certainly not surprising because it is so complicated and there's so much bleed over. So I figured if we had a little bit more time, I'm going to talk about 2 of these, just 2 examples to really kind of illustrate, one, that there's complexity here, but 2, that there are things that organizations are and can be doing. And first of all, labor costs, it's a huge consideration, as I mentioned before, but in any service business it is, and healthcare is no different. So sure, we've got regulators and others pushing standards and, folks looking for higher wages and whatnot, all the typical things that you see and encounter. That's part of the deal, but it doesn't mean you can't optimize it. And one of the ways to do that is, as I mentioned, kind of alluded to before, is managing demand. So a few things to think about, continuing with this health system example, is just questions. How connected are specialists and hospitalists to your emergency department, and what communication protocols are in place to get people out of there and into beds? Or, in speaking of the emergency department, how do your admission stats look? Are you overly conservative as an organization? Can you get folks back in the ambulatory world as opposed to admitting them? I mean, these are pretty hardcore things to be thinking about, but they're all very real, and we know there's opportunity in almost every organization out there. Do your nursing floors, including the docs, the physicians, of course, have plans, for every inpatient possible, that they're sticking to those plans, and I mean care treatment plans. So these are care pathways and discharge plans. It's more than what day and time of the week your physicians are rounding, and are they showing up on weekends to do appropriate discharges on those days, but are there discharge order sets and things the tangible things that you can do proactively to manage this stuff. They're all things that can be optimized, and wherever we go with our clients, we find massive opportunities that have profound impacts there. Key takeaway here is that for labor anyway, is that it's got to go beyond benchmarking and the notion of cuts. It's optimizing. Now, benchmarking is absolutely critical. Don't get me wrong. That's an important aspect in any of this. But when you're talking about longer term sustainable change, you've got to focus on these other areas that can impact your labor cost. And I want to talk a little bit about service lines as well. And this sort of noisy graphic, if you will, is something that we use and customize based on need. It's kind of like the first page in a tool that we use, and it doesn't have everything on it. I more wanted to just illustrate this complexity of service lines. And what we're talking about here is within a healthcare system, how do you manage your cardiovascular, or how do you manage your orthopedics? How you do that can have a very important impact on success overall in a bunch of different ways. When we think of the fully optimized service line, it incorporates, stuff that goes on outside of the walls of the hospital, if you will. But that's how you sort of maximize the ROI and the connectivity with physicians, awareness in the marketplace, and it drives quality all at the same time. It's hard enough to think, about a service line that happens, within the four walls. You have, referrals, you've got ED access, surgery, supply, what happens on the nursing units and ICUs, discharge planning, et cetera. That inpatient experience is important, but, for any leaders, service line leaders or system leaders, but in order to maximize the value of the effort, you've got to kind of get beyond the four walls. We had a recent example that involved an analysis at a client, just to give an example on the cardiovascular side, how important it is for the overall service and the impact you can have on your facility. If I'm sticking with this theme of, mitigating some of the cost issues in a system, the CardioMEMS is an implantable monitoring device in the cardiovascular world. And we're working with a client, and they learned that there were more of these than expected being implanted on an inpatient basis. And the theory has it that if you catch the syndrome, the need for this on an in the ambulatory world before you get into the hospital, it can avoid admissions in a meaningful way. And not only that, but actually, frankly, it pays better on the outpatient side. It costs less, and which helps everybody. And it also will avoid admissions. So your patients are being handled differently and being kept out of the hospital, which at first might not sound that great, but when you look at the way that whole realm of reimbursement, cost, and quality works, it's kind of solving a lot of problems. And it's just one example of probably thousands that are out there. So everybody kind of wins in that. I don't have any intention of painting an overly idealistic image, but the outcomes can and should be transformative if you have your service lines dialed in. And who benefits from it? The health system does, the patients do, the physicians do, and at least in theory, this could bleed back to the payer world and all of us as sort of taxpayers and folks who pay healthcare premiums as well. The last thing I want to mention quickly is just how important structure is. And forget what's on the graphic. This is just illustrative. We just grabbed some graphs, but you want to be able to make sure you track what you're doing. You want to have, we deploy in our clients, we deploy a program management office kind of a structure that's driven by leadership, led by the key folks in the organization, has some discipline and accountability and structure to it, because you're talking about managing a large number of projects to solve a problem. But that's really sort of the nuts and bolts of how you achieve the transformative type of change that we're talking about. And we think, quite frankly, and a lot of leaders across the country are saying the same thing, that you're going to have to be doing this type of stuff in order to really manage your long-term sustainability and, frankly, deal with a lot of what's coming with the sort of the technical end of the PHE. Ultimately, what gets done gets measured is sort of how that saying goes. So a couple other areas that we touched on briefly throughout the presentation. I think we're kind of running out of time here. So just note that there are the more practical blocking and tackling areas too that are very important. Hospital-acquired infections being one of them that really fell off during the pandemic for good reason, because frankly, our dear friends, the clinicians working in the hospital world, were not able to. They didn't have the benefit of time to be able to continue to manage this during this the craziness of the pandemic. So we really took some steps back. But these are important areas that are generally considered blocking and tackling. So with all of that, I know I threw a lot out there, but Stacy, I'm going to turn it back over to you.
All right. Well, we certainly covered a lot. It's in an hour and a half, which seemed to go by really fast. So thank you for that, Karl. As we move to closing, I'm going to actually throw it back to each of the panelists here and in rapid fire mode, see if they can give a key takeaway in 10 words or less. So Mike, how about we start with you?
I think a key takeaway is to take advantage of as much real-time, fresh information as possible. A lot of what I talked about is tied to a cost report. You can't wait 12 months from now to find out what happened.
Great. Richard.
For me, it's looking at these regulatory changes as just as essential to your strategy as market considerations or technology or anything else.
All right, Melaney.
Absolutely. So I would say from kind of my perspective and lens is really utilize your compliance and internal audit departments as much as possible to help keep you all safe and ready for the changes that are coming.
All right, and Karl, get the last one.
No sacred cows, no stones unturned, and have a disciplined process. Don't be afraid to look at anything and everything as you try to enhance the sustainability of your organization.
Great, thanks everybody, and thank you to our speakers here today. As I mentioned, we always think we're going to get to the questions and we run out of time, so we will be responding to those. There's some additional slides here just as reminders for you. We do have our contact information here, so if you have any follow-up questions, want to reach us directly, you can find our information here in the slides. And then we want to make sure just to bring to your attention, some of you may have been to our Executive Healthcare Conference. Our 2023 conference is in the works, in the planning stages, and we certainly would love to have you there at our conference this year, November 2nd and 3rd. You can find more information in the link there in the presentation as well. And then just lastly, some upcoming webcasts that we have that are on the next slide. We always are trying to stay ahead of information and get content out to the market, so you can check those out and also check our website as well for anything that may have been in the past and that you can listen to on demand as well. So again, thank you everybody for joining. We appreciate you taking the time out of your day. Have a great day.